The endocrine system involves organs found all over the body, derived from literally every type of primordial germ layer. Many of them have unusual and highly testable embryology. That being said, most of our embryology is organized in the respective organs-based chapters. Most of it's in repro with stuff about the pancreas and the GI section, and stuff about the pituitary and adrenals and endocrine anatomy. If you're reading along with first aid, you'll see that in endocrine embryology, we generally just focus on the thyroid gland. But after we do this, I encourage you all to check out those other sections just to get a sense of the awesome diversity of the endocrine system's origins. Our story actually begins with the tongue, which, as you may know, is born in 3 parts from the floor of the pharynx, the 2 anterior thirds from the floor of the oral cavity, and the posterior third from the pharynx. But at the midline, where all 3 parts of the tongue meet, an invagination occurs. The invagination deepens into a pocket of endoderm called the thyroid diverticulum, which eventually grows into the lobes of the thyroid gland. And the connection, known as the thyroglossal duct, should normally be obliterated, and all that remains is a small divot where the 3/3 of the tongue meet. Remember what that area is called? This little divot's known as the foramen cecum, found right here. So that's how the majority of the thyroid develops, at least the part that produces thyroid hormone. Remember the other type of cell in the thyroid, the one that doesn't get any love? The majority of the thyroid is organized into follicles that produce T3 and T4, but interspersed between them are the parafollicular cells that secrete calcitonin. And these are actually derived from the neural crest cells that are floating around in the sea of mesoderm. By the way, even though parafollicular cells and calcitonin aren't really tested that heavily on step 1, they're pathologically relevant in that neoplasia of these cells produces one of the most aggressive types of thyroid cancer, medullary thyroid carcinoma. In fact, you can follow the progression and resolution of medullary thyroid carcinoma by tracking levels of calcitonin in the serum. Now, our jobs as physicians wouldn't be nearly as much fun if things didn't go wrong every now and then, and indeed this is something they love to test. For starters, the most distal portion of the thyroglossal duct may fail to obliterate completely, leaving a pyramidal lobe in the center of the thyroid. It doesn't actually cause any dysfunction, but kind of messes up that snappy bow tie look the thyroid normally has. What actually may be a minor problem is if the duct remains patent and forms a cyst along its tract. These cysts are often the culprit in midline neck masses of the pediatric population, usually found right around the level of the hyoid bone, but really they can be anywhere between the tongue base and the thyroid cartilage. The main testable point to remember is that there's another common type of cystic neck mass found in kids that you'll have to distinguish from the thyroglossal cyst. Remember what that one is? It's the branchial cleft cyst, but unlike the thyroglossal cyst, this lesion's found at the lateral aspect of the neck. More on this one in the reproductive chapter. Furthermore, the thyroglossal cysts actually move with the motion of the tongue because of their attachment via the foramen cecum, and that's not something you're going to find with a branchial cleft cyst. Finally, the thyroid may actually fail to descend altogether, which results in a lingual thyroid. Apart from being a pretty weird place to find a thyroid gland, these thyroids are often hypofunctioning, and are actually a pretty common cause of congenital hypothyroidism. But enough about thyroids. It's time for a flash quiz. Fill in the blank. Normally, blank is the only adult remnant of the thyroid's connection to the tongue. Go ahead and pause the video if you need a couple seconds to think about this one. The answer is the foramen cecum, found in the midline of the tongue between the anterior 2/3 and the posterior 1/3 of the tongue. It's the divot that remains after the thyroglossal duct is obliterated. So, grossly speaking, the pituitary gland is that dangly jobby that sits beneath the hypothalamus at the base of the brain. Remember what that part of the skull is called? The one with the pituitary inside? It's called the sella turcica, or the Turkish saddle. No idea why they thought the base of the skull looked Turkish. Anyway, what looks like Mexico with a pair of testicles is actually my attempt at a schematic diagram of the hypothalamus and pituitary, divided up into the functionally distinct anterior and posterior pituitaries. There's the intermediate lobe, which you really don't have to know anything about for step 1, except that it produces melanotropin, which stimulates melanocytes to make you darker. Now, the cool thing is that, much like the adrenal gland, this gland is diverse in its embryologic origin. Remember that buzzword that's always associated with the anterior pituitary's embryology? Rathke's pouch? It's derived from surface ectoderm by a process that you don't actually have to be familiar with, but simply knowing the name Rathke's pouch equals easy points on step 1. Now this is sort of your gland portion, like the adrenal cortex. So where does the posterior pituitary come from? Hint, it's in the alternate name for the posterior pituitary, the neurohypophysis. Basically, like the adrenal medulla, the posterior pituitary is of neurologic origin. In this case, neuroectoderm, and not neural crest, because we're in the central nervous system. Remember your embryology. Neuroectoderm equals CNS, and neural crest equals PNS, generally speaking. So, the blood supply here is particularly interesting, because it's home to the second, and far less famous, portal venous system, the hypophyseal portal system. And like the more famous hepatic portal system, it's present to ensure that the products of the first capillary bed are routed straight into another capillary bed before they have the chance to hit the systemic circulation. In this case, the hypothalamus secretes trophic hormones through the circulation that control the release of 6 hormones from the anterior pituitary. We'll talk a lot more about these feedback loops in the physiology section, but by and large, they're pretty intuitive. So, how does the hypothalamus control the secretion of hormones from the posterior pituitary? Alright, you can relax. That wasn't really a fair question, because the posterior pituitary is actually just made up of axonal projections from the neurons in the hypothalamus. So there's no trophic hormones traveling through the portal system like there is for the anterior pituitary. The hormones are simply generated in the cell bodies in the hypothalamus and are escorted down the axon by chaperone proteins called neurophycins, and then get released by the modified axon terminals specialized to release hormones into the bloodstream instead of into a synapse or a neuromuscular junction. Pretty cool, huh? There are 6 hormones total that are produced by the anterior pituitary. Think you can name them all? Go ahead and pause the video. I'm not going anywhere. So, the hormones are FSH, LH, ACTH, TSH, prolactin, and growth hormone. And these hormones conveniently form the mnemonic flat pig. No, not a fat pig, a flat pig. Ah, cute. Look, he's standing on the first aid sign. Anyway, cells of the pituitary gland are histologically divided up into basophils and acidophils based on how they stain. Basophils staining either blue or purple depending on the stain, and acidophils staining a brighter red. The flat hormones of the flat pig series are produced by basophils, and the pig hormones are produced by acidophils. Now, I want to clear up one bit of confusion about acidophils and basophils. These are not 2 different cell types. Those are just descriptions of how they stain. The 5 different cell types secrete 6 different pituitary hormones, and it just so happens that the corticotrophs, gonadotrophs, and thyrotrophs all take up base and stain blue, so we call them basophils. Similarly, both lactotrophs and somatotrophs take up acids and stain red, so we call them acidophils. You got me? Finally, 3 of the flat hormones, which are secreted by the basophils, actually look pretty similar. FSH, LH, and TSH all have the same alpha subunit. It's the beta subunit, however, that gives these hormones their specificity. Interestingly enough, this structure is also shared by another non-pituitary hormone. Remember what it is? It's human chorionic gonadotropin, a hormone similar to FSH and LH in that it promotes the secretion of progesterone. In large enough doses, HCG's alpha subunit can even trick the body into thinking that it is TSH, which can actually cause the symptoms of hyperthyroidism. You can see this in patients with HCG-secreting neoplasms, like gonadal tumors or hydatiform moles. Adrenocorticotropic hormone is the odd man out amongst the basophils. It's synthesized from a large protein precursor called pro-opiomelanocortin. And if you're thinking, wow, that's a mouthful, how am I ever going to remember that? Just remember that this precursor molecule allows you to synthesize not just 1, but 3 other hormones. The opio stands for the body's endogenous opioid, or beta-endorphin. The melano stands for melanocyte-stimulating hormone, promoting the synthesis of melanin in the skin. And cortin, of course, stands for everyone's favorite ACTH. What happens is the precursor molecule that's generated gets cut up into 3 pieces, generating all 3 hormones. Beta-endorphin release is controlled pretty tightly, but MSH levels in the blood tend to rise when ACTH levels do. That's why, in conditions where ACTH goes through the roof, like Addison's disease, the skin tends to darken, because of increased MSH. Alright friends, time to see what you guys learned with another flash quiz. We talked a lot about hormones today. Now let's see if you can name the hormones secreted by acidophilic cells. Pause the video if you need some time to think. The answer is prolactin and growth hormone, otherwise known as somatotropin. As a refresher, the anterior pituitary hormones are flat pig. FSH, LH, ACTH, and TSH are all secreted by basophils, whereas prolactin and growth hormone are secreted by acidophils. Now, let's go back to our friend the posterior pituitary, just to see if you were listening the first time. Where are these hormones produced? The answer is the hypothalamus. Now, there's two hormones that are produced here, so it's not quite as crazy as the anterior pituitary. Vasopressin is produced in the supraoptic nuclei of the hypothalamus, and oxytocin is produced in the paraventricular nuclei. My mnemonic, and I have no idea why nobody's thought of this before, is VSOP. For those of you who don't know, it's a grade of cognac that means my drink is better than yours. So think about that posterior pituitary next time you pass the Courvoisier.
Hey gang, it's your favorite teacher Arjun again, here with some endocrine anatomy. As with our other videos, we here at First Aid like to ask questions, and it's not because we like to hear ourselves talk. Even though you could wait the 1 or 2 seconds it takes to hear the answer, I strongly encourage you to try to come up with some of the answers on your own. It'll help keep you engaged and give you sort of an idea of how well you actually remember some of this stuff. Endocrine anatomy's not too intense, so let's dive right in. Let's start with our friends the adrenal glands sitting right on top of the kidneys. A quick gross anatomy rundown. Venous drainage differs by side, much like the gonads. The left adrenal drains into the left renal vein before it hits the IVC, whereas the right adrenal drains directly into the IVC itself. Arterial blood supply is threefold and comes from the phrenic artery, the aorta, and the renal artery. It's not the best diagram, but actually it's the venous drainage that ends up getting tested most often. Identifying the adrenals on a CT can be a little bit tricky, especially if you're used to seeing images like these that represent the adrenals as purely superior to the kidneys. I'll give you a moment to play Where's Waldo with the adrenals. Try to locate these for yourself. And by the way, ignore this huge gallstone. We'll call that an incidental finding. As you can see, they're not only superior, but also anteromedial to the kidneys. Remember from renal that the left kidney, and thus the left adrenal, sits a little bit higher than the right. Now normally they look a little bit like the inside of a Mercedes-Benz logo, but as always there's a bunch of fun pathology that can make them look pretty wacky. Now it'd be pretty sadistic for the step 1 folks to make you identify adrenal pathology on CT, but if you know what a normal adrenal gland looks like, you should be able to identify a gross abnormality like a mass, in the event that they ask you to identify one. So that's gross anatomy. Now let's take a cross-section of our friend the adrenal gland and pick it apart from the outside in. The adrenals are surrounded by a fibrous capsule, but the most important structural and functional distinction is between the steroid-producing cortex and the catecholamine-producing adrenal medulla. The cortex is divided up into 3 zones, each one of which contains a different arsenal of enzymes to generate a different set of steroids. From outside to in, the zones are named glomerulosa, fasciculata, and reticularis. Remember G, F, R. Like the kidneys, they're sitting right on top of. These zones are responsible for the production of mineralocorticoids, glucocorticoids, and weak androgens, respectively, which regulate salt, sugar, and sex. They say the deeper you go, the sweeter it gets, because as we all know, sex is hilarious. But real talk, the activity of these hormones is a lot more complicated than just salt, sugar, sex, so we'll go into them in a lot more detail in the physiology section. Now this is more of a physiology point as well, but it's worth asking. What hormone do you expect is the primary regulator of the steroids produced by the adrenal cortex? Hint, it practically has adrenal cortex in the name. Adrenocorticotropic hormone, or ACTH, is the primary regulator of both glucocorticoids and adrenal androgens, but it actually has almost no control over the secretion of mineralocorticoids. Mineralocorticoids, exemplified by aldosterone, are functionally a part of the renin-angiotensin axis, and are generally feedback regulated by the blood pressure. Again, that's a gross oversimplification, so be sure to check out the renal physiology section for a much better explanation. What is the germ layers the cortex and medulla are derived from? The cortex is derived from mesoderm, and the medulla, which acts almost like a postganglionic sympathetic nerve, is derived from ectoderm, specifically neural crest. So if ACTH controls the release of steroids from the cortex, what hormone releases catecholamines from the medulla? I'm just kidding, that was a trick question. Unlike most stuff in the endocrine section, this one doesn't work on the hypothalamic pituitary axis. Instead, it works a lot like the rest of the sympathetic nervous system. As you may remember, the SNS always involves two peripheral neurons, one preganglionic neuron that synapses onto a postganglionic neuron that then synapses onto a muscle fiber. In this case, the preganglionic neuron synapses onto the adrenal medulla, which releases epinephrine and norepinephrine, much like any other postganglionic sympathetic nerve. However, instead of secreting it onto a muscle fiber, the adrenal medulla secretes epinephrine and norepinephrine straight into the bloodstream. While we're on our fun little tangent back into autonomic land, anyone remember the neurotransmitter secreted by the preganglionic neuron? It's acetylcholine, and it's picked up by nicotinic ACH receptors. And that's going to be the same no matter whether you're in the adrenal medulla or in a postganglionic sympathetic neuron. You should be able to identify the various functional layers of the adrenal gland from a histologic specimen as well. If you can, try to orient yourself and figure this one out on your own. Remember, they may not give you a nice easy orientation, but you'll still be expected to recognize the cell types for the exam. Alright, time's up. Let's do this one together. So, the pathologists out there will probably not like my explanation for this, so I'll go ahead and address this right off the bat. Yes, the terms glomerulosa fasciculata and reticularis apparently refer to the histologic appearance of the cortical layers, and no, I've never been able to see it. The people who get this are probably just more sophisticated than I am, but I'll just tell you what I think is the easiest way to tell these apart. First, the capsule and the medulla are pretty easy to spot. The capsule is mostly collagen, with very few cells scattered around the inside, and the medulla is much more basophilic. It's got sort of a porous appearance to it due to the many vascular channels that are inside of it. So that just leaves the three layers of the cortex. Take a moment to try to demarcate those on your own, and let's see if you still remember the order of the cortical layers. So if the order is G, F, R, then the fasciculata is the middle layer, and I'll highlight it for you right here. So it's recognizable by its porous appearance, but unlike the medulla, it's not porous because it's highly vascular. It's porous because the lipid droplets, which are not preserved on the slide, appear like multiple little pores. Remember, the zona fasciculata produces cortisol, the eponymous steroid of the adrenal cortex, and therefore hoards the most cholesterol. The glomerulosa is closer to the capsule, and the reticularis is closer to the medulla. The reticularis actually contrasts really nicely with the medulla because it's very eosinophilic, or red-looking, and the medulla is very basophilic, or blue-looking. You got all that? Good, because now it's time for another flash quiz. What is the middle layer of the adrenal cortex, and what does it produce? And the answer is the zona fasciculata, which produces cortisol. Not so painful, right? Okay, I think that's about enough for the adrenal gland. Let's move on to the captain of the SS endocrine itself, the pituitary gland.
The pancreas is a multifunctional little organ that looks like a gross pink fatty ball of meat socked away in the recesses of the retroperitoneum. Today, we're going to specifically take a look at the cells responsible for endocrine regulation. The pancreas is divided functionally and anatomically into the excretin portion that lines the pancreatic ductal system and secretes digestive enzymes, and the endocrine portion. And this being endocrinology, this is the portion we're going to focus on today. The endocrine pancreas is composed of small islands of cells interspersed between the exocrine cells in clusters known as the islets of Langerhans, and these are richly vascularized to monitor glucose levels in the blood and respond by secreting the appropriate levels of hormones into the bloodstream. The islets are made up mostly of beta cells, with alpha cells at the periphery. And you remember what these produce? The alpha cells produce glucagon, and the beta cells produce insulin. There's also a smattering of somatostatin-producing delta cells, but the really important ones to remember are the alpha and beta cells. And literally, that is all I'm going to say about them for right now. There's a lot more to be said about each of these hormones, but I'm not going to ruin the surprise for you. For now, let's test your recall with a flash quiz. Your question is, where are the alpha cells located, and what hormone do they secrete? And the answer is, alpha cells are at the periphery of the islets of Langerhans and secrete glucagon. Bottom line is pretty simple. Endocrine cells, the alpha, beta, and delta cells, are clustered in the islets of Langerhans. Alpha cells secrete glucagon, beta cells secrete insulin, and delta cells secrete somatostatin. And that's all, folks. See you around.
The complete hypothalamic pituitary axis involves up to 3 different levels of signaling: hypothalamic hormones, anterior pituitary hormones, and the hormones secreted by the gland controlled by the anterior pituitary. I find it easiest to start off with the anterior pituitary hormones. Remember the mnemonic for those? The mnemonic is flat pig, which stands for FSH, LH, ACTH, TSH, prolactin, and GH. This is actually a great mnemonic because it logically groups the hormones by function as well as by acidophils and basophils. Now, FSH, LH, TSH, and ACTH, the basophils, are trophic hormones, whose primary responsibility is to regulate hormone synthesis at the end organs. FSH and LH, the gonadotrophs, increase the synthesis of sex steroids of the gonads, which we'll talk a lot more about in repro. ACTH primarily increases the synthesis of cortisol at the adrenal cortex, and TSH increases the synthesis of thyroid hormones at the thyroid gland. Prolactin and GH, on the other hand, are not trophic hormones. Their effects go directly to the end organs. So, how does the hypothalamus exert control over the anterior pituitary? For the most part, each hormone is controlled by a releasing hormone that the hypothalamus shoots down the hypophyseal portal system. Can you remember which releasing hormones stimulate which anterior pituitary hormones? Go ahead and pause the video and see if you can get them all. And remember, there's one odd man out. The release of gonadotrophs is stimulated by gonadotropin-releasing hormone, ACTH is controlled by corticotropin-releasing hormone, and TSH is controlled by thyrotropin-releasing hormone. All pretty logical. There's just a couple of weird things to remember. The first is that gonadotroph cells in the anterior pituitary adapt really quickly to GnRH. They actually downregulate their receptors in response to sustained elevation of GnRH. You'll learn more about this in repro, but sustained GnRH analogs are actually used to suppress sex hormones. So in physiologic conditions, the hypothalamus has to secrete GnRH in a pulsatile fashion to properly stimulate the gonadotrophs. The second weird fact is that corticotroph cells in the anterior pituitary synthesize ACTH from a precursor called pro-opiomelanocortin. What? What'd he say? Well, turns out it's not that hard. It's just 3 separate hormones that come from one precursor because the ribosomes decided they were going to phone it in. Pro-opio stands for opioid, meaning beta-endorphin, or the body's endogenous opioid. Melano stands for melanocyte-stimulating hormone, which potentiates the skin cells to increase melanin. Cortin obviously refers to ACTH. Beta-endorphin gets regulated by other means, but in situations where ACTH production gets cranked to 11, like Addison's disease, you generally also see an increase in skin pigmentation because of increased synthesis of MSH. In keeping with the flat pig mnemonic, prolactin and GH work a bit differently. GH is modulated not only by growth hormone releasing hormone, but also by growth hormone inhibiting hormone, otherwise known as somatostatin. Sound familiar? Yeah, it's actually the same hormone as the one that brings all GI activity grinding to a screeching halt. but extremely high concentrations of somatostatin are required to inhibit the secretion of growth hormone. It's almost impossible for the gut secretion of somatostatin to influence the anterior pituitary because by the time it reaches the brain, it's been diluted by pretty much the entire blood volume. The hypothalamic capillary bed, however, drains straight into the pituitary capillary bed via the hypophyseal portal system, and that ensures minimal dilution. Finally, prolactin is tonically secreted at baseline. It doesn't require any hypothalamic stimulation. It does, however, require constant suppression at baseline, to prevent people from lactating willy-nilly. To make this even more wacky, this inhibition doesn't even occur through the hypophyseal portal system like the others. There are actually hypothalamic neurons that travel down the pituitary stalk and use the neurotransmitter dopamine to inhibit prolactin release. Most of these undergo pretty logical feedback inhibition. For example, when cortisol levels get too high, cortisol inhibits ACTH and CRH to prevent cortisol levels from spiking out of control. I'm not going to put them all up here because that would clutter up the diagram, but it's mostly intuitive. That isn't quite the case for sex hormones, which gets a little complicated, especially in females, but again, we'll leave that to repro. But this type of feedback inhibition that I'm talking about occurs within its own hypothalamic pituitary axis. What I want to go over is the few bits of cross-regulation that occur between these otherwise totally isolated axes. These aren't very intuitive, but they are quite high yield and have some pretty significant clinical consequences. First up, and possibly most important, is prolactin. Prolactin inhibits GnRH, effectively shutting down the production of sex steroids. Now, this is such an important effect of increased prolactin that you're more likely to see menstrual disturbance, decreased libido, and other sexual side effects before you see galactorrhea. So what are some instances during which you might see increased prolactin? Alright, you can be unoriginal and say prolactinoma, and yes, you'd be correct. But another reason for elevated prolactin is if dopamine isn't doing its job inhibiting prolactin. We call this disinhibition. So tell me, what drugs commonly cause a patient's dopamine to drop, disinhibiting prolactin? This is one from the psychiatry section. It's the antipsychotic drugs. This is a side effect that's present in all generations of antipsychotic and can actually be pretty troublesome. The final cause of elevated prolactin is actually the second of the important cross-regulatory pathways you need to know. As it turns out, thyrotropin-releasing hormone stimulates prolactin as well as stimulating TSH. And, be careful before you answer this, what condition in the thyroid gland can cause elevated TRH? The answer is hypo, not hyperthyroidism, which makes sense, because if the thyroid hormones normally feedback suppress TRH, then decreased T3 and T4 will disinhibit TRH. But Arjun, says you, what if the hypothyroidism is caused by increased TRH? To which I say, stop being a smartass and hunting for zebras. According to Dr. Wikipedia, 999 times out of 1,000, the cause of weird T3, T4 levels, either high or low, is going to be at the level of the thyroid gland itself. The last bit of cross-regulation I want to talk about is how GHIH, or somatostatin, also inhibits TSH, effectively causing secondary hypothyroidism. This is a lot lower yield than the other two pathways, and there's really only one clinical example I can think of that represents this pathway as well. Octreotide, a souped-up somatostatin analog, is sometimes used to treat an excess of growth hormone. What's one major side effect? You guessed it, hypothyroidism. So, one more time. The cross-regulatory pathways that aren't so intuitive. Prolactin inhibits GnRH, TRH stimulates prolactin, and GHIH, or somatostatin, inhibits TSH. The posterior pituitary hormones work a little bit differently. Unlike the anterior pituitary that involves a complex bit of signaling through trophic hormones, the posterior pituitary doesn't make use of the weird portal system. Instead, it just synthesizes hormones in the cell body of the hypothalamic nuclei, then transports them down the axons of the infundibulum, where they get released into the bloodstream by the posterior pituitary and reach their target organs. Remember the two posterior pituitary hormones? Vasopressin, otherwise known as antidiuretic hormone, and oxytocin. Both vasopressin and oxytocin have important physiologic and pharmacologic functions. Vasopressin's two names indicate its two main functions: vasopressin, indicating its function in increasing peripheral vasoconstriction, and antidiuretic hormone, indicating that it prevents diuresis, or water loss, through the kidneys. The regulation of ADH is discussed a lot more in its own section of endocrine physiology, but the feedback loop is pretty self-explanatory. Vasopressin is secreted in the pituitary in response to the hypothalamus sensing either low blood pressure or excessively high solute concentration. Vasopressin fixes the first by vasoconstriction, and the second by reclaiming free water from the distal tubules. Oxytocin's best known peripheral functions are both female specific. The milk letdown reflex, simulated by tactile stimulation of the nipple, and uterine contraction at the moment of labor. Now, obviously, you have to memorize these hormones because step 1 is arbitrarily decided you need to know what they are to be a doctor, but these hormones do have important pharmacologic uses as well. Vasopressin is pharmacologically used to support the blood pressure in critically ill patients, and is arguably the most important non-adrenergic pressor used in critical care medicine today. If you're going into OBGYN, Pitocin is going to be your best friend, since stimulating uterine contractions can help speed along a slow labor and help clamp down on bleeding vessels after the baby has been delivered. Turns out patients don't like it that much though, since strong uterine contractions are exactly what suck most about labor. Interestingly, both are known to be central nervous system neurotransmitters, as well as peripheral hormones, and both play a role in social bonding and relationships, but the peripheral functions are a lot better known and therefore going to be a lot more easily tested. And speaking of testing, I think it's time to test your knowledge of hormones with a flash quiz. Alright, that's a lot of ground to cover, so here's the trickiest thing you'll be expected to remember. How does prolactin affect the level of sex steroids synthesized in the body? Pause the video if you need to reason this out. So, most of endocrine physiology is pretty straightforward, but there is some crosstalk between the hormonal axes. The most important of which is that prolactin directly inhibits GnRH, causing the sex steroids to decrease. The most important clinical correlate of this is that since dopamine inhibits prolactin, a lot of anti-dopaminergic drugs, like the antipsychotics, will disinhibit prolactin and therefore suppress the synthesis of sex steroids. And don't forget that since TRH stimulates prolactin, that there's a whole extra dimension of this whole interaction between prolactin and sex steroids. I'll let you review that one on your own. If you like this video, go ahead and hit the thumbs up button down below, and as always, please comment since your feedback makes my videos better. Arjun Iyer, signing out. Now we're going to tackle growth hormone, our other non-trophic hormone secreted by the anterior pituitary. Like a lot of hormones, GH has some pretty wide-ranging effects. Now, call me weird, but whenever that happens, I like to give the hormone a profile, or a personality if you will. It allows you to group the hormone's seemingly disparate effects into something that makes a little bit more sense. For example, I think of growth hormone as the orthopod bodybuilder. Why orthopod? Because it's all about the muscles and bones, baby! Growth hormone is sometimes thought of as an anabolic hormone, but that's mainly true for the musculoskeletal system. Its main physiologic role in childhood and adolescence is to cause linear bone growth, whereas in adults, it causes mostly bone thickening. And from a muscle standpoint, GH not only promotes bone protein synthesis, but also directly causes the muscle fibers to hypertrophy. But in fact, GH isn't purely anabolic, because our ortho boy needs fuel to build up those guns. Glycogen stores are mobilized to deliver glucose to the tissues that need it, and adipocytes break down their stored triglycerides and release circulating free fatty acids. Building up protein in bone ain't cheap, from an energy perspective, and together these mobilized substrates provide the ATP needed to power this sort of heavy-duty anabolism. If you're looking at the growth hormone profile and thinking to yourself, building up muscle and burning fat and carbs? Man, how can I upregulate my growth hormone and get in on that? Well, our ortho bro has 2 bits of advice for anyone looking to get into the bodybuilding game. The first is simple: lift hard and sleep hard. Every bodybuilder knows that maximizing your muscle gains isn't just about exercising hard during the day, it's also about getting a good night's sleep to jumpstart your recovery time. You see, growth hormone release is pulsatile, but it increases with both sleep and exercise. Diet's an equally important consideration, and our orthopod's recommendation is to go paleo. If you're gonna get swole, bro, you gotta maximize the protein and minimize the simple sugar. Amino acids, especially arginine, stimulate growth hormone, but glucose decreases its release. So according to this slightly more formal flowchart we see here, growth hormone gives you bulging muscles and bones of steel, and burns fat and carbs. I mean, what more could an orthopod bodybuilder want? As it turns out, there are a couple of not so great side effects that are very much related to the anabolic and catabolic consequences. First, while it makes your muscles swell up, it does the same to almost all of your organs. At best, that means you get a big tongue and a big gut from all the growing your intestines do. Probably some of you gym rats out there have heard of the phenomenon known as palumboism, where modern bodybuilders with access to large quantities of pharmaceutical-grade growth hormone get bigger than previously thought possible, but get these big gorilla guts that bodybuilders in Schwarzenegger's time didn't have a problem with. But that's more cosmetic than anything. A more serious consequence of indiscriminate muscle hypertrophy is heart failure from cardiac hypertrophy. Just ask Andre the Giant, the unfortunate product of a pituitary gland gone haywire, who died of cardiac complications. Second, in an effort to mobilize glucose and lipids, growth hormone actually blocks the effects of insulin by promoting insulin resistance. It's one of two main diabetogenic hormones. Anyone remember the other? The other one's cortisol, and both of these can lead to the many sequelae of diabetes in the long run. Last point about GH. It does a lot on its own, but a lot of its effects, especially the anabolic ones, are mediated through a liver hormone called IGF-1. And actually, measuring IGF-1 levels will give you a better indication of growth hormone than simply doing a random one-time GH sample. Can you guess why? The reason is because GH release is pulsatile. If you took a random sample, it could be at a peak, a trough, or anywhere in the middle. The level of IGF, however, is a lot more consistent. Alright friends, I know this probably inspired you all to get off your butts and get into the gym, but hold tight, it's time for a flash quiz. Here's a question on a side effect of growth hormone that's pretty heavily tested. What is the effect of growth hormone on the serum concentration of glucose? And the answer is, growth hormone increases the serum concentration of glucose. The purpose of this is ostensibly to support anabolic activity in the musculoskeletal system, but this also leads to the hormone becoming potentially diabetogenic. That's all for now, folks. If you learned something today, don't forget to hit the thumbs up button down below. And as always, your comments are welcome and in fact actively solicited. Arjun Iyer, signing out.
Let's talk about a majorly important crossover topic that straddles endocrine, renal, and cardiovascular physiology: the regulation of fluid homeostasis. First, let me ask you, why do people get thirsty? It's not a trick question. The answer is to let them know they need to drink water. Duh. And when do we need to increase our water intake? Well, the answer to this question is a little trickier. The most obvious answer is when we're dehydrated. More accurately, when we're hypovolemic. This is mediated by angiotensin II and arterial baroreceptors that communicate with the more primitive areas of the brain to let it know, hey man, we need más agua. The less obvious reason to drink more water is that our blood's too hypertonic. Think about it. Water isn't a replacement for the fluids in our body. Normal saline is. Water is extremely hypotonic, meaning that the other function of drinking fresh water is to dilute the blood. Osmoreceptors in the central nervous system communicate with the hypothalamus to tell it that the sodium concentration is getting too high. So now that the central nervous system is aware of the fact that it needs water, it does two things. First, it communicates with the limbic system of the cortex to actually get you to drink water, which both increases the body's fluid volume and decreases the sodium concentration. At the same time, the hypothalamus releases antidiuretic hormone via the posterior pituitary, which works on the kidneys to achieve exactly the same goals as drinking water: increase the fluid volume and decrease the sodium concentration. But let me be clear, there are a lot of systems in place to help fight hypovolemia and hypotension. ADH's most important role is to decrease the sodium concentration in the blood. And to understand how this works, it's helpful to contrast it with another important hormone, aldosterone. Both aldosterone and ADH are important when it comes to fluid retention and maintaining blood pressure, so it's particularly important not to mix these up. First, while aldosterone stimulates the retention of saline solution via the active reuptake of sodium and the resulting osmosis, ADH leads to the retention of free water. It does this by stimulating the insertion of sequestered aquaporins into the apical membrane, allowing water to passively osmose into the interstitium and eventually the capillaries. As you can see, ADH really does pretty much the same thing as just going out and drinking water. But wait a minute, why does inserting pores willy-nilly into the membrane mean that water is necessarily going to osmose out of the renal tubule? Doesn't it depend on the osmotic gradient? Well, remember from renal, the renal interstitium, especially in the medulla, is extremely salty. Remember all that countercurrent gradient stuff? It's okay, I won't make you think about it. But the bottom line is, if you punch holes in the renal tubule, water is always going to come rushing out to dilute the salty renal interstitium, because that's where the osmotic gradient's leading it. Aldosterone does a couple of other important things at the kidney, including potassium and hydrogen ion excretion, but the important contrast between ADH and aldosterone is, though both of them cause fluid retention, the different composition of the fluids means that ADH is capable of modulating the osmolality of the blood, whereas aldosterone is not to any significant degree. ADH dilutes the blood by reclaiming free water from the urine, meaning that if your ADH goes up, then your urine must by default become more concentrated. Now, it may seem obvious when I present this information, but being able to come to these conclusions on your own is crucial to answering endocrine pathology questions and doing well on step 1. So, to answer the question that led us to the slide in the first place, what is the primary purpose of ADH? I think you can all get this one now. The unique purpose of ADH is its ability to modulate the osmolality of the blood. To sum it up, antidiuretic hormone responds to hypovolemia and hyperosmolar blood by causing free water retention, which decreases the osmolality of the blood. And it does so via the V2 receptors on the distal tubules and the collecting ducts. In response to low blood pressure, ADH additionally causes arteriolar constriction via the V1 receptors, and this is what gives it the alternative name vasopressin. Failure of this pathway causes diabetes insipidus, where instead of retaining free water, you pee out too much free water, leading to a ton of very dilute urine and leaving you with very salty blood. Historical fact, the name insipidus means bland, and it's from the day where, instead of scut work, interns were required to do things like taste people's pee and go, this one tastes sweet, this one tastes bland, this one tastes like E. coli. You know, the good old days. And this kind of goes into the pathology section a bit, but there's a couple ways to mess this up. If you're not able to secrete or produce ADH, you call that central diabetes insipidus. And how do you fix a deficiency of any hormone in endocrinology? Easy. Just supplement the patient with its synthetic equivalent. In this case, the name is desmopressin. If the problem's with the V2 receptor rather than the hormone itself, you call that nephrogenic DI. And this is a lot trickier. The treatment depends a lot on what's causing the receptor not to work and whether it's partial or complete loss of function, but the first line, if you can't control the excretion, you've got to strictly control your intake. Now, pause the video and take a good look at this diagram if you need to, because after you do, you're in for a flash quiz. Here's a fill-in-the-blank question for you. Antidiuretic hormone's main effect on the renal tubular epithelium is to increase the surface expression of blank, which causes water to move into the blank via osmosis. Go ahead and pause the video if you need a moment to think. And the answer is, antidiuretic hormone's main effect on the renal tubular epithelium is to increase the surface expression of aquaporins, which causes water to move into the renal interstitium via osmosis. For the second blank, I also would have accepted renal capillaries because that is where the water eventually ends up.
So, we all know what prolactin does, right? It's all in the name. Prolactin, promotes lactation. Now, lactation takes a few different hormones to work, and the primary responsibility of prolactin is to stimulate the glands to produce milk. It does not, however, cause milk to be expressed from the breast. That's the job of oxytocin, a hormone that gets discussed a little bit more in repro. Furthermore, while prolactin does help with the development of the glands, the responsibility primarily falls to progesterone and estrogen, both of which are also at nuclear levels during pregnancy. While we're on the note of pregnancy, let me talk quickly about the complex way in which prolactin and the gonadal axis interact, because it gets a bit weirder than I described in the previous slide. Estrogen stimulates the pituitary lactotrophs, which causes prolactin levels to skyrocket, along with the sex steroids at the end of pregnancy. So what prevents mom from milking all over the place in the third trimester without any baby to feed? As it turns out, while estrogen keeps on ramping up the production of prolactin, progesterone prevents it from actually doing anything by inhibiting its effects on glandular breast tissue. When the baby's delivered, the mega doses of progesterone drop rapidly, quickly disinhibiting prolactin and resulting in rapid milk production. Estrogen drops too, but the high levels of prolactin are maintained by breastfeeding, which centrally inhibits dopamine. Like I said before, the inhibition of the hypothalamic pituitary gonadal axis is a critically important effect of prolactin. We talked about some pathologic reasons for elevated prolactin, but physiologically speaking, prolactin is the main reason that breastfeeding women do not get their menses back for quite some time after pregnancy. Any guesses as to why that might produce an evolutionary advantage? As the theory goes, if mom's breastfeeding, that means she's already expending a lot of resources on one baby, and it would take a pretty big toll on her body to add another pregnancy to the mix, so prolactin goes ahead and suppresses her menstrual cycle so she can't have another one. So we talked a lot about prolactin, which arguably has some of the least intuitive regulation in this section. Let's see if you've mastered the beast with another flash quiz. Which of the following would you expect to decrease the production of milk? Haloperidol, primary hypothyroidism, or progesterone? This is kind of a tricky one, so take your time and pause the video if you need to. And the answer is progesterone. Remember, progesterone directly inhibits the effects of prolactin on the milk glands, decreasing milk production. The other two increase secretion of prolactin. Primary hypothyroidism causes feedback disinhibition of TRH, which stimulates prolactin secretion. And haloperidol, an antipsychotic, decreases the levels of dopamine in the brain, which disinhibits the secretion of prolactin. I recommend you go back to those diagrams in the video if you're still uncomfortable with these. It can take a couple of looks to figure out.
Okay, this is a fun one. If you hadn't already realized, I'm a huge weirdo, and whenever a hormone seems to act on multiple body systems, I give it a personality to make all the different effects stick. The thyroid hormones T3 and T4 are the ones everyone wants to be. They've always got the energy to go out and party, and the metabolism to shred through heinous amounts of beer and nachos they consume on a regular basis. Then you realize, that was you once upon a time. Ladies and gentlemen, I present to you T3 and T4, the college freshmen. First of all, these guys have ridiculous amounts of energy, but how the heck do they keep going? As it turns out, T3 and T4 are potent potentiators of catecholamines on the sympathetic nervous system, especially the cardiovascular system. Essentially, they amplify the effects of epinephrine in the body, leading to all the sorts of things you'd expect. Faster heart rate and increased contractility, faster respiration, and increased psychomotor activity, and even agitation, just to name a few. Y'all know what adrenaline does. I'm not going to bore you by listing everything. If you want a refresher, take a look at the pharmacology section. Second, as most people remember wistfully, early college was a time when your metabolism seemed like it'd never fail on you, no matter how much junk you ate or drank. So how do these party animals chomp through all that fuel? The thyroid brothers' crazy metabolism is the result of increased activity of the sodium-potassium ATPase, which in normal cells takes up a whopping fifth of the cell's total energy. That breakneck pace of the enzyme generates a lot of heat through metabolic inefficiency, but requires additional fuel in the form of mobilized glucose and lipids to support the ATP generation. Of note, the increased metabolic rate also increases the rate of oxygen consumption, which is yet another contributor to the increased respiratory drive. It's worth mentioning again that if a hyperthyroid patient doesn't work to increase their calorie intake, they tend to lose weight. As it turns out, most hyperthyroid patients do increase their food intake, but not enough to account for their radically increased metabolism. Weight loss despite increased food intake is a very unique pair of symptoms that should always make you at least think of hyperthyroidism. Finally, college is a time of learning and development, and college freshmen are primarily concerned with developing their ability to think and their ability to bone. Hey, before you get mad at me, you pervert, I meant their bones. T3 and T4 are important regulators of growth and development, notably bone growth, where it works synergistically with growth hormone, and of the central nervous system. These effects are particularly noticeable in infants, and infant hypothyroidism leads to a very preventable syndrome involving short stature and mental retardation. They used to call it, I kid you not, cretinism, but needless to say, nobody calls it that anymore. So that covers the basics of what thyroid hormone is and does, but the mechanics of how T3 and T4 operate within the body are pretty fascinating and definitely testable. So let's follow these party animals to their origin story and how they're synthesized in the thyroid gland. The thyroid gland, if you didn't know, is arranged into multiple microscopic follicles. The follicles, in turn, are made up of surrounding cells that are responsible for controlling the process, and the lumen, where all the magic happens. Probably the most important thing to know about thyroid synthesis is what two ingredients thyroid hormone is derived from. One is iodine, obviously. The other is the amino acid tyrosine. Basically, the follicular cells toss iodide ions into the lumen of the follicle, along with these massive hunks of protein with tyrosine residues sticking out from all over them. This is called thyroglobulin, not to be confused with the transport protein thyroxine binding globulin. Now here's where the magic happens. Thyroid peroxidase, this wonderful enzyme that hangs out in the lumen of the follicle, does three things at once. It oxidizes iodide to iodine, iodinates the tyrosine residues, and conjoins them to form what basically looks like T3s and T4s sticking out of a protein ball. The T4s are made of two diiodinated tyrosines, and the T3s are made of one diiodinated and one monoiodinated tyrosine. So, which part of this is regulated exactly? Well, when TSH stimulates the follicles to do so, that massive clump of thyroglobulin is endocytosed. Lysosomes fuel with the vesicle, lysing the protein component but sparing the T3 and T4 units. These are then secreted into the bloodstream when TSH permits it. T3 and T4 get released by the thyroid gland under the direction of TSH and ultimately TRH. But before we get too far down this pathway, why do I keep saying T3 and T4 in the same breath like I can't decide what I mean? What's the difference? As it turns out, T4 is the primary form secreted by the thyroid gland, and it's imported into the cells where it can then exert its effects. But T4 is actually the wimpy version of the hormone. T3 is the real deal, and the target cell is generally responsible for converting T4 to its more active form by clipping off one of the iodides attached to it with an enzyme called 5' deiodinase. There's a small amount of T3 that's generated by the thyroid follicles, like I mentioned, but the majority of T3 is generated by intracellular conversion. Speaking of transport, T3 and T4, like cortisol, are lipophilic. So what bearing does that have on the transport through the bloodstream? The thyroid twosome has to be carried by a transport protein because they're poorly water soluble, and that protein is creatively named thyroxine binding globulin, or TBG. Not to be confused with which protein? Thyroglobulin, and if you mix these up on the test, I will seriously hunt you down and slap you in the face. Anyway, TBG is a great reservoir for thyroxine in the bloodstream, but the only thyroid hormone that can actually enter cells to exert its effects is the tiny bit that's not bound to TBG. Let's call it free T4. But here's where things get interesting, and try to stay with me on this. Say you have a condition where you're low on protein, for example, liver failure. Your TBG synthesis, like the rest of your protein synthesis, is gonna tank. So what do you suppose happens to your levels of free thyroxine when the bottom suddenly drops out of the TBG pool? Suddenly, your pool of free thyroid hormone is dramatically increased, which transiently increases the activity of thyroid hormone. Don't worry, it doesn't last long enough for anyone to be symptomatically hyperthyroid. The additional free thyroxine feeds back on the hypothalamus and pituitary, suppressing the TRH and TSH. So what clinical significance does this have? Well, none really. The feedback suppression normalizes the free T4 levels and everything is hunky-dory. The patients are clinically euthyroid, meaning that they have none of the symptoms of either hyper or hypothyroidism. But this does make for some interesting diagnostic snafus, because if you measure the total amount of T3 or T4 in the bloodstream, are the levels going to be high or low? The measured total T3 and T4 will be artificially low, despite the fact that the patient is clinically euthyroid. It's a good thing to remember when doing thyroid tests on individuals what medical comorbidities are known to change the amount of blood proteins synthesized by the liver. Medical conditions that decrease the synthesis of blood proteins, and therefore the total measured levels of T3 and T4, are liver failure, nephrotic syndrome, and chronic glucocorticoid use. Hyperestrogenic states are probably the best known for increasing the amount of synthesized blood proteins, so in these, your measured T3 and T4 are going to run high. Last point on thyroid hormone. An excess of thyroid hormone can be dangerous, even lethal, so it's important to know the points where the path of thyroid hormone activity can be cut off. There are two antithyroid drugs, propylthiouracil and methimazole, that both primarily act by inhibiting the synthesis of thyroid peroxidase. In addition, PTU also inhibits the conversion of T4 to the more active form by inhibiting 5' deiodinase. There's two other drugs that also inhibit peripheral conversion, and those are the glucocorticoids and the beta blocker propranolol. And hey, guess what's extra cool about propranolol? Remember how thyroid hormones exert a bunch of their effects by upregulating the beta adrenergic receptors? Well, propranolol, being a beta blocker, inhibits that aspect of thyroid hormone as well. Wow, that's a lot of thyroid stuff. Ready to test your knowledge? Alright, then it's flash quiz time. Question: thyroid hormone increases metabolism by increasing the rate of sodium-potassium transport. True or false? The answer is true. Congratulations everyone, you finished up with the physiology of T3 and T4. If you liked the video, go ahead and click on that thumbs up down below, and as always, comments are more than welcome. Arjun Iyer, signing out. So to start off this topic, it's helpful to refresh this concept. What is the ultimate goal of parathyroid hormone? The goal of PTH is to rapidly increase the blood calcium at all costs, even at the cost of stripping it from the bone. And the way that PTH accomplishes this isn't completely intuitive. So as it turns out, osteoclasts don't actually have a PTH receptor, but they do have a receptor responsible for their activation called RANK. The hormone that activates osteoclasts, RANK ligand, is actually secreted by the osteoblasts and osteocytes, which do have PTH receptors. So PTH indirectly causes increased osteoclast activity by causing the osteoblasts and cytes to secrete RANK ligand. Now this ends up activating a specific transcription factor pathway called NFKB, which I think of as no fix, kill bone, the code word to unleash the beast inside of the osteoclast that causes it to go on a destructive rampage and break down the mineral parts of bone. The broken down bone mineral gets released into the bloodstream into its component parts, calcium and phosphate. Like vitamin D, PTH stops the kidneys from excreting calcium, but it also promotes phosphate excretion. Now hold on there, PTH, says you. What do you got against phosphate? Well, remember, simply providing the phosphate and calcium as substrates for the osteoblasts, like vitamin D does, promotes spontaneous mineralization of the bone, which is completely counterproductive to what PTH is trying to accomplish. Worse yet, the spontaneous mineralization can actually happen in other places, such as onto the blood vessels. If PTH wants to keep more calcium in the blood, sorry phosphate, but you're going to have to go. Finally, PTH actually stimulates vitamin D activation in the kidneys, which really confuses a lot of people because they think of PTH as the yang to vitamin D's yin. But remember, young Padawan, the universe exists with yin and yang in harmony. I'll tell you what I mean. PTH has the immediate solution for increasing blood calcium, but isn't concerned with pesky things like sustainability. While the bones have a lot of calcium to spare, we kinda need them to, support us and stuff. It's like chopping apart bits of your house for firewood. Sure, it's a decent fix in the short term, and your house probably has a lot of wood in it, but sooner or later, you're gonna have to go out to the forest and get some actual wood for both the fire and the bits of your house that you just ruined. How does vitamin D help fit that bill? By stimulating gut absorption of both phosphate and calcium. That way, you can rebuild the bone, and if it's too much phosphate for PTH, well, you can always tell the kidneys to go excrete some more. As you might expect, PTH is stimulated by low calcium and high phosphate, which makes sense from a feedback perspective. Where it gets a little kooky is that it's also regulated by magnesium. Low magnesium, like its divalent brother calcium, leads to increased PTH. But to make matters really weird, really low magnesium actually inhibits PTH. So why is this clinically relevant? Because magnesium derangements can lead to PTH derangements. Most commonly, severe hypomagnesemia leads to clinically significant hypoparathyroidism, because mild hypomagnesemia tends to correct itself. Now there's a lot of things that can cause magnesium wasting. Diarrhea, diuretics, alcohol abuse, and the aminoglycosides among them. Now, these can, in many cases, cause hypocalcemia and hyperphosphatemia as a result of the inhibition of parathyroid hormone. Just remember that in these patients with similar histories, correcting the magnesium is critical to correcting the calcium and phosphate. If I were to ask you where you could find calcium in the body, where would you first look? If you said bones, you'd be right. That's where over 99% of the body's calcium is found. But the calcium we're primarily interested in, at least in this section, is the fraction of a percent found in the blood, because maintaining this vital electrolyte's concentration within a tight range is crucial for normal physiology. So, where would you expect to find circulating calcium? Free calcium ions are certainly an option, and they make up about 45% of the circulating calcium. The remaining calcium is bound to either albumin because it's negatively charged, or circulating organic anions. Now, because I know how much y'all love chemistry, let's take a look at the sizable minority of calcium bound to anions. Free calcium is in equilibrium with the calcium bound to anions, usually organic acids, meaning that they associate and dissociate in a ratio that's determined by how much of each is present in the blood. Starting to get flashbacks to chemistry yet? What would happen if, say, there was suddenly less of the organic anion available? With less anion to bind calcium, there will be more free calcium released. And it just so happens there is a pathologic phenomenon that can decrease the amount of organic anion able to bind calcium. It's called more acid. Now hold on a minute, Arjun, says you. How the hell does more acid make less acid? Simple, because the conjugate base of the organic acid is the one that binds to calcium. If the blood pH decreases, by definition, there's more H+ ions in the blood. And just like the positive calcium can bind to the negative conjugate base, positive hydrogen ions can also bind to the acid. You can think of H+ ions as competitive inhibitors of calcium binding. So what then does acidosis do to calcium? It causes hypercalcemia, as alkalosis causes hypocalcemia. Before taking step 1, I would have thought this a trivial point, but I swear to you, this does come up on the exam. Well, that about covers it for what you need to know about the homeostasis between the different forms of circulating calcium, because ultimately, only one type of calcium is physiologically active and monitored by the body. The free calcium, or ionized calcium, as it's called on lab assessments. The fun part is the regulation of how calcium enters the body via the GI tract, exits the body via the kidneys, and the equilibrium of circulating serum calcium and the massive repository of calcium on the bones. You'll learn a lot more about calcium metabolism in the endocrine section, but one of the most important things to remember is that calcium homeostasis is inextricably tied to the homeostasis of phosphate, because that massive calcium repository that is the human skeleton is also a massive repository of phosphate in a mineral called hydroxyapatite. So, if you want to take out a calcium loan from the skeleton bank, so to speak, you're going to have to free up some phosphate from the bone as well. There are two main hormones responsible for maintaining calcium homeostasis: vitamin D and parathyroid hormone. Now, there's independent sections on each of these, but the most important thing to remember is that vitamin D is primarily concerned with obtaining calcium substrate for the bone from food, both calcium and phosphate, whereas parathyroid hormone is primarily concerned with increasing serum calcium rapidly, which invariably involves taking it from the bone. But because calcium and phosphate are both released, parathyroid hormone's secondary function is to increase the excretion of phosphate that you get from the breakdown of hydroxyapatite. It's a bit more complicated than that, but it's helpful to know the general gist of how each hormone contributes to calcium homeostasis. Calcitonin is the black sheep of the calcium regulation hormones, and unlike vitamin D and parathyroid hormone, this one doesn't really get any love on step 1. And it has absolutely nothing to do with phosphate. But as far as calcium goes, this one acts pretty much like the anti-parathyroid hormone. Its goal is to decrease blood calcium in response to elevated levels of calcium. It stops the osteoclast from breaking bone down for calcium, stops the gut from absorbing calcium at all, and actually stimulates calcium excretion in the kidneys. And while it may seem like you'd need calcitonin as sort of an opposing hormone to PTH, calcitonin is actually not that functional in humans. It's kind of like the appendix or pinky toe, basically just a vestigial hormone. When the body needs less PTH activity, the main way it goes about that is just to decrease the secretion of PTH. Interestingly enough, since calcitonin hasn't really been that important in our lineage ever since mammals split off from our reptile-like ancestors, our particular isomer of calcitonin has degraded to become a weakly binding shadow of its former self, without any evolutionary consequence. It's so non-functional that if you need to use pharmacologic calcitonin, say in extremely hypercalcemic patients, you don't use human-type calcium. You use salmon calcitonin. That's right. Our fishy friends still carry a version of calcitonin that binds about 40 times as strongly to the calcitonin receptor as ours. The more you know.
Now, once you know insulin, glucagon's not really too hard to get the hang of. In many ways, it's kind of like the anti-insulin. Insulin is secreted by beta cells in response to hyperglycemia, whereas glucagon, well, I'll let you do this one for me. What's glucagon secreted by? The alpha cells, right? In response to hypoglycemia. Insulin operates via the intrinsic Y kinase pathway, whereas glucagon is just your average Y-bread G protein coupled stimulatory pathway. Insulin lowers the blood sugar and promotes anabolism by inducing glycolysis, promoting glycogen storage, and by promoting fatty acid and triglyceride synthesis. So what does glucagon do for the metabolism? It raises the blood sugar and promotes catabolism by inducing gluconeogenesis, glycolysis, lipolysis, and ketogenesis. So that's the easy part. What's harder is knowing the deviations from the opposite game I just played in front of you. First of all, insulin deals more directly with protein anabolism, whereas glucagon, as far as we know, doesn't have any direct effects on protein metabolism. Glucagon also doesn't have any effects on glucose transportation, whereas insulin upregulates it on certain cells. And finally, insulin kicks glucagon's butt any day of the week. It can directly prevent the alpha cells from producing glucagon. And I think that about covers it for these two hormones. There's actually a lot more important stuff regarding the effects of insulin and glucagon on specific metabolic pathways, but that's covered in way more detail in the metabolism section of biochemistry. Your job, when you're done listening to me, is to go review that section of biochemistry and see where insulin and glucagon regulate carbohydrate metabolism, because now you'll be reading it with a sense of perspective.
Insulin is one of the most important hormones in endocrinology, and you should spend some serious time on this because it's not only high yield, its effects and regulation are actually pretty complex. But before starting with the nitty-gritty biochemical mechanisms, I want to start by going over what I consider to be the core of endocrinology, the cause and effect of homeostasis. So to really generalize, what's the purpose of insulin? The purpose of insulin is to coordinate the body's resources during times when glucose is plentiful, primarily through anabolism, or building up complex molecules. Well, how does it do that? Well, the most intuitive way the body deals with a surplus of glucose is to store it, and that job goes primarily to our three reliable friends, the skeletal muscle, the liver, and the adipose tissue. When glucose is plentiful, insulin causes skeletal muscle to import and metabolize more glucose and store it as glycogen. The process is similar for adipocytes, but logically, fatty acid and triglyceride synthesis is the primary means of storage. The liver's a little different. Insulin actually has no power to control the transport of glucose into the liver, but it does cause increased glucose metabolism. But which does the liver preferentially synthesize? Glycogen or fatty acids? Preferentially, the answer is glycogen, but the liver's glycogen tanks fill up pretty quickly. When the storage capacity has been reached, fatty acid synthesis becomes pretty important, because the liver can always count on the adipocytes to help with the storage. And the net adipocyte capacity is way bigger than the liver's capacity to store energy. The liver just has to package the fatty acids up as triglycerides and send them off with a VLDL postmark. Finally, insulin has a couple of important effects on all cells, not just the trifecta above. If insulin is an anabolic hormone, what would you expect its effects to be on protein metabolism? Insulin causes increased amino acid uptake and protein synthesis in all cells while inhibiting proteolysis, which makes sense since protein synthesis takes a ton of ATP that's only really found when macronutrients are plentiful. And finally, for real this time, insulin increases the activity of the sodium-potassium pump, which may seem pretty trivial now, but it becomes pretty important in the treatment of hyperkalemia. Check this out in the renal section on potassium regulation. So hopefully that was a helpful demonstration of the big picture of insulin. Now I'm going to get into the mechanisms of how these regulations take place. Let's start with the secretion of insulin itself. This humble rectangle represents the beta cell, the place where it all begins. Before glucose even enters the picture, this tiny warrior cranks out granules of stored insulin day and night. The hormone is actually synthesized as a prohormone and packaged into vesicles. Now this is where the magic happens. Inside the vesicles, proinsulin is cleaved to form active insulin and the inactive C-peptide. These granules full of insulin and C-peptide park themselves right by the cell membrane, ready to be secreted at the drop of a hat. So the question of the day is, as always, why does anyone care? The real clinical value, and the one you'll be asked about on step 1, is C-peptide's ability to distinguish between different etiologies of hyperinsulinemia. Think about it. If you've got an insulinoma, you'll have high levels of both insulin and C-peptide in your blood. What about if you've just taken a mega overdose of regular subcutaneous insulin? I don't think so. Endogenous insulin is always accompanied by the co-release of C-peptide, but remember, exogenous insulin is never accompanied by C-peptide. How you get from high glucose to insulin release is a bit of a complicated song and dance that you unfortunately have to memorize for this test, but it's actually quite a bit easier when you see it animated than on paper. So, first of all, more glucose on the outside of the cell means more glucose transport into the beta cell, where it then gets catabolized to generate ATP. What follows is an inhibitory step where ATP actually deactivates an ATP-sensitive potassium leak channel. Without the leak channels working, K+ builds up on the inside of the cell, creating an increased positive charge that therefore depolarizes the beta cell. Now, this inhibitory step is always the hardest for me to remember, and unfortunately it is an important one clinically as well. One of the major classes of diabetes medication, the sulfonylureas, increase endogenous insulin synthesis specifically by allosterically blocking these very same channels, in a way bypassing the glucose sensing step of insulin release. The depolarization of the cell opens everyone's favorite vesicle releasing channel, the voltage-gated calcium channel. Just like at an axon terminal, this allows calcium to enter and permit vesicle release. Now, this whole shenanigans is upregulated by a set of gut hormones called the incretins. They're discussed a lot more in the GI section, but the one you have to remember is GLP-1. When the cells in the GI tract sense sugar, they release GLP-1, increasing insulin synthesis by a variety of different mechanisms even before the sugar hits the bloodstream. That's why an oral glucose load will actually spike your insulin more than an IV bolus will. So now that we've taken a look at insulin release and regulation, let's see what it does when it's at its target. Insulin's actions are mediated via the intrinsic tyrosine kinase, or MAP kinase pathway. It's one of the more esoteric pathways, so I'll quickly take you through how it works. Insulin binds to an intrinsic tyrosine kinase receptor, giving each subunit the ability to add phosphate groups to the other. Once autophosphorylation takes place, a whole host of adapter proteins glom onto the activated receptor, the final result being the activation of two proteins, phosphoinositol 3 kinase that acts in the cytoplasm, and MAP kinase, which translocates to the nucleus to control gene expression. What does the signal cascade accomplish? As a matter of fact, everything you see right here. So now we're going to get into the cell-specific effects of insulin and how the different types of cells respond to insulin. We'll start with glucose transport. So remember how I said that insulin facilitates glucose transport in muscle and fat cells, but not the liver? The reason is, both myocytes and adipocytes possess vesicles containing the GLUT4 transporter. And insulin's P13K pathway causes the vesicles to integrate with the cell membrane, increasing the cell's ability to import glucose in the presence of insulin. In the case of striated muscle, the GLUT4 transporters can also be translocated to the membrane with exercise, which explains why exercise is so important for insulin-resistant diabetic patients. Can you think of a way this might go wrong? You're probably not used to thinking of exercise as a harmful thing, but this is actually a pretty common cause of hypoglycemia that you might see on step 1. Patients who take insulin are supposed to decrease their insulin dose before exercising to account for the dual drop in blood sugar, but when they forget, it can lead to some pretty significant hypoglycemia. So how does the liver get its glucose? We talked about the myocytes and adipocytes. What about the hepatocytes? Well, those use the GLUT2 transporter, a transporter that isn't controlled by insulin. Now, we're going to go into this transporter in some detail, and I know it's weird to spend so much time on a transporter that's not insulin dependent during the, insulin chapter, but this transporter is pretty unique. The first cool thing about it is that it's bidirectional. Glucose can either enter or exit the cell. Now, why is that so important for the liver? Because unlike other cells, the liver doesn't just want to suck up all the nutrients it can. As the major reservoir of glycogen for the body, it needs to be able to secrete glucose into the bloodstream when the body's in the fasting state. GLUT2 is also important on cells that have an apical and a basolateral side. Basically, cells that have glucose on one side of the cell that they need to get over onto the other side. Can you think of any cells like that? The small intestine is probably the first one that comes to mind because it needs to get glucose from the gut into the body. But the other equally important one is the proximal tubule cells of the kidney. They need to move all the glucose in your urine back into the body. GLUT2 is used to export glucose from inside the cells to the body's interstitium. But how do you get glucose into the cells in the first place? Hint, it's not a GLUT transporter. All the GLUT transporters are purely for passive diffusion, which is fine because in most cases the cell just takes what it needs, and where there's low glucose concentration, more diffuses in. But when your goal isn't just to get enough glucose, but rather every last little bit, well then you need to kick it up a notch. You could use active transport, but why spend energy to gain energy, right? To solve that problem, nature invented the SGLT channels, which stands for sodium glucose transporter. In a genius move, the cells harness the power of the extracellular sodium gradient to drive glucose into the cell along with a sodium molecule. Pretty slick. The only problem is, you have to pair it with a GLUT2 on the opposite side to help glucose escape the cell, because otherwise you're just going to pump glucose in so fast that the cell will literally explode. Other than bidirectionality, the enzyme kinetics of GLUT2 are pretty special, and for those of you who want to smack your heads against the desk at even the thought of biochemistry, well, you can skip ahead to GLUTs 1 and 3 because this isn't honestly that high yield. The reason I'm presenting it is, I really think it helps you understand why this transporter is where it is in the body. At lower and most physiologic glucose concentrations, GLUT2 transports glucose slowly compared to GLUT4. For the liver, that means letting other tissues have first dibs when supplies are low. But it also has an insulin-independent mechanism for picking up the pace when glucose levels are too high. The GLUT4 transporter maxes out pretty quickly, but 2 has a high capacity for transporting large amounts of glucose. To use the terms you learned in pharmacology, GLUT4 has the lower Km, which means higher affinity, but GLUT2 has the higher Vmax. In the liver, this is one of the mechanisms for preventing critical hyperglycemia. If blood glucose starts to go haywire, the liver can keep sucking up glucose faster and faster. In the kidney and small intestine, it means that GLUT2 can rise to the challenge if the SGLT channels are threatening to increase intracellular glucose concentrations to cell-exploding levels. So I explained why the liver, small intestine, and kidney need GLUT2, but the pancreatic beta cells also make use of the bidirectional transporter. And this is a little less intuitive. So why use GLUT2? Because the beta cells need to know when there's a lot of glucose so they can secrete a correspondingly large amount of insulin. Think about it. If they had a low capacity transporter, they'd increase their levels of insulin until about a concentration of 120 milligrams per deciliter, at which point they'd be all, well, I'm about done here. And that's bad news bears. We want our beta cells to be able to modulate insulin levels over a wide range of glucose concentrations. There are a few other important glucose transporters, none of which is regulated by insulin. For starters, these two behemoths, GLUT1 and GLUT3, are very high affinity, high capacity transporters. Now, carrying high levels of these transporters is basically like having access to an all-you-can-eat buffet of glucose, even in times of starvation when glucose is scarce and insulin's bottoming out. So, which cells deserve first dibs on glucose? Well, the brain certainly comes to mind, as does a close extension of the CNS, the eyes. And as you might remember from repro, fetuses also get first dibs on glucose in a pregnant mother. Placentas are chock full of GLUT1 and GLUT3 transporters because fetuses are basically like tiny parasites that hog all of mom's resources to grow. That's why even when mothers get hypoglycemic, it's very hard to make a fetus hypoglycemic. The last type of cell that gets one of these mammoth transporters is kind of surprising. The humble red blood cell. Now, what makes these guys so special that they get an all-access pass to glucose heaven? Remember, RBCs have no mitochondria and can't undergo anything more efficient than anaerobic metabolism of glucose. So they need to chew up a ton of glucose to meet their energy requirements because they're physically incapable of oxidizing fats. The last of the glucose importers is this weirdo called GLUT5, and it's actually a fructose transporter. There aren't too many cells that use fructose, but the small intestines can absorb it and convert it to glucose for the rest of the body, and sperm actually do use it primarily for energy. If you're having trouble remembering these, don't worry, you're not alone. If you have to triage your knowledge, GLUT4 and GLUT2 are the most highly tested, followed by SGLT. Remember that GLUT2 is a two-way street, unlike the other ones, and that it's found in the liver, paired up with SGLT in the small intestines and kidneys and in the beta cells. GLUT4 is insulin dependent, and it's on the muscles and the adipocytes. Alright, my friends. That's a lot of information on insulin, and nearly all of it's important, so I think it's time for a flash quiz. We'll keep this quick. Which glucose transporter is the slowest at low glucose concentrations? Go ahead and pause the video if you need time to think. And the answer is the GLUT2 transporter, found on both the liver and pancreatic beta cells. Thanks for watching, citizens of RX, and if you liked the video, don't forget to give me a thumbs up down below, and as always, comments are more than welcome.